Welcome to the deep dive. Our subject today, well, it's incredibly foundational, isn't it? But also profoundly complex. We're talking about the strategic principles, the precise practice of rational drug therapy, and we're drawing specifically from the world of pediatric care, which adds layers of complexity. This is really the kind of material that separates the competent from the truly elite professional. And we're going to break it down, really get deep into the rationale, the critical calculations, and those non-negotiable precautions.
That's absolutely right. Our mission here is to master this material, truly. We're looking at synthesizing just an immense amount of high-stakes, very specific data, covering everything from emergency antidotes all the way through to long-term chronic management. And we won't just be listing doses. That's not the point. We have to understand the core indications, the why behind the strict rules, and frankly, the severe, sometimes irreversible consequences of getting it wrong. This is about turning dense pharmacological tables into, well, a strategic, actionable blueprint for patient safety.
Okay, let's lay that groundwork right away. Establish the intellectual foundation. We have to start by defining rational drug therapy, or RDT. It's not just, picking the right drug. It's more of a commitment, isn't it, to a really stringent framework. What are those 6 core summarizing principles that really govern this practice?
RDT, yeah, at its heart, it's really a framework of clinical restraint and precision. The very first principle, the absolute starting point, is the necessity of a genuine, confirmed indication for the medication. Simple as that. If the indication isn't truly there, the drug's out, no question. The second principle mandates using the minimum number of agents necessary. And those you select, they must be appropriate for the specific task. They need to be familiar to you, the prescriber, and ideally inexpensive and, importantly, verified to be of good quality. This whole approach helps prevent unnecessary polypharmacy and, those potential drug interactions.
That point about familiarity, that feels highly strategic, doesn't it? It suggests that knowing the nuances, maybe the side effects of 3 drugs you know inside out is maybe safer than bringing in a new one you haven't quite mastered yet, even if it seems slightly better on paper.
Exactly. Familiarity breeds mastery, especially of the side effect profile. That's crucial. Okay, moving on. The third principle is mandatory. Prescribing by the generic name. Always. This reduces confusion, especially across different healthcare settings, and, well, it often significantly reduces cost, too. Fourth, the dosage. It must be absolutely optimum for the desired benefits. We're always looking for that sweet spot, between efficacy and toxicity. It's a balancing act. Fifth, preference must always be given to the oral route whenever it's medically viable. It's just less invasive, reduces the risk of infection, and often helps with compliance long-term.
And the final principle, maybe the most demanding, especially in pediatrics, it involves foresight, doesn't it? Looking ahead.
Absolutely. The sixth principle is that crucial need to anticipate, actively monitor, and then expertly manage adverse drug reactions, or ADRs.
Yeah.
It means thinking about every medication, not just as a tool for healing, but also as a known risk, a risk that has to be actively mitigated right from the moment you prescribe it. And we also have to remember true drug synergism, where 2 drugs work much better together than alone. It's exceedingly rare. Cotrimoxazole is one exception the sources mentioned, but generally combining antibiotics, say, is reserved for when you don't know the causative agent, or maybe to prevent resistance, like we see in complex TB management.
Right, and we absolutely must anchor this whole discussion in that unique challenge of pediatric pharmacology. The sources are crystal clear that development dictates dosage. It's not one size fits all.
Profoundly so. Yes, developmental factors, genetic factors, things like differing levels of liver enzymes or changing renal function as kids grow, these profoundly affect how a child metabolizes and responds to a drug. So it means doses must be continually modulated. You adjust based on the individual patient's response and, crucially, the specific disease state. Think about it. The dose of an antibiotic needed to really penetrate the central nervous system for something like meningitis. It's going to be orders of magnitude higher than the dose you'd use for a simple skin infection or, say, pyogenic arthritis. The disease state itself fundamentally alters the therapeutic target and the dose required.
Okay, great foundation. Let's start unpacking this, starting with managing pain and fever. We'll begin with the analgesics. This is an area where some really common drugs carry some of the most critical, non-negotiable warnings.
Let's start with aspirin then. Salicylates. The strategic use of aspirin in pediatrics today, it's rarely for just general pain relief anymore, not like it used to be. Its really crucial uses are in these chronic high-stakes conditions. like acute rheumatic fever. That requires massive doses. We're talking 90 to 120 milligrams per kilogram per day.
It's huge.
Yep.
That is
Yeah.
a huge dose. Wow.
Yeah.
And then for Kawasaki disease, you mentioned the dosing is strategically biphasic. 2 parts.
Yeah, it's a very deliberate two-stage approach. Initially, to knock down that intense inflammation, you start really high, 80 to 100 milligrams per kilogram per day. High dose. But then, once the fever breaks, which signals you're getting control of the disease, you drop the dose dramatically, down to low maintenance dose, just 3 to 5 milligrams per kilogram per day. And this low dose continues for quite a while, maybe 6 to 8 weeks, until those inflammatory markers, things like the platelet count and the ESR, normalize. And that low dose, it's primarily for its antiplatelet aggregation effect at that stage. Yeah.
Okay, and right here is where we hit that ultimate example of Principle 6, anticipating the adverse reaction, the critical warning. We have to talk about Ray encephalopathy.
Yes, this is foundational, a non-negotiable rule in pediatric prescribing. There's a clear, severe epidemiological link between using salicylates in children and developing Ray encephalopathy. It's rare, thankfully, but it's potentially fatal. Involves swelling of the liver and the brain. Therefore, the bottom line is using aspirin for generalized upper respiratory tract infections, things like the flu, or even just fevers where you don't know the cause. In children, it's simply not advisable, period. We have to constantly counsel parents and caregivers against this. And just a practical point, always avoid giving it on an empty stomach. Helps minimize that gastric irritation.
Okay, moving to paracetamol, or acetaminophen as it's known elsewhere. We know the general dose is 40 to 60 milligram a day, or maybe 15 milligram kilogram dose, but because it's so available over the counter, the potential for toxicity seems immense.
It really is. It's probably the most common potential poisoning risk we see in kids, just because it's in every household. The severe adverse effects to know are skin rashes, but crucially, that dose-dependent hepatotoxicity, liver damage, which can be fatal. And there's potential for renal damage, too. Mastering paracetamol means understanding that the margin of safety is actually surprisingly narrow, especially when you're dealing with high-volume, repetitive dosing, like for persistent fever. This makes vigilant parental education absolutely mandatory. You have to stress the correct dose and interval.
Right. Then we pivot to the NSAIs, like ibuprofen and naproxen. Their main pediatric use seems to be more long-term in juvenile idiopathic arthritis, GHAI. Exactly. GHAI is a chronic inflammatory condition, so the anti-inflammatory doses here are sustained and they're pretty high. Ibuprofen typically runs from 30 up to maybe 70 milligrams per kilogram per day. Naproxen is usually 10 to 20 milligrams per kilogram per day, but that's given every 12 hours. And always after meals. Again, got to protect that GI mucosa.
And then there are these specialty NSAIDs, which seem to carry unique specific risks we need to isolate. Diclofenac, mefenamic acid, and indomethacin.
Yeah, diclofenac, even at its lower dose range of 1 to 3 millicule a day, significantly increases the risk of gastric bleeding and ulcer formation. You have to be wary. Mefenamic acid, those is a dual threat, seizures, which is serious, and also gastric bleeding. So these are definitely not drugs you'd prescribe casually, especially not first line.
Indomethacin is really fascinating, though. It perfectly illustrates that idea of pharmacologic specificity. Its dose isn't just based on weight or general age group, but on the specific physiological maturity of a neonate's cardiovascular system, specifically for ductal closure.
That's the absolute key. It's a dose-dependent use for a highly specific, time-sensitive condition. The source material, in Table 30.1, explicitly shows the dosing regimen for patent ductus arteriosus, the PDA. And it's stratified, broken down into neonates less than 48 hours old, those 2 to 7 days old, or those greater than 7 days old. The dose changes with age. Beyond that very specific neonatal use, its side effects include things like oliguria, reduced urine output, which you need to monitor, plus hypoglycemia and platelet dysfunction.
Before we move into the opioids, let's quickly flag tramadol. There's a critical age restriction there.
Yes, very important. Tramadol must be strictly avoided in children below 14 years of age. That's due to the risks of seizures and potentially serious renal or hepatic dysfunction in younger kids. So 14 is the cutoff.
Okay. Now we enter the realm of narcotic analgesics, the opioids. Here it feels like rapid onset, extreme potency, and the absolute need for immediate reversal capability really define the practice. Let's start with fentanyl.
Fentanyl's potency is, well, it's staggering, really potent. A tiny amount, just 0.1 milligram, gives you the same analgesic effect as 10 milligrams of morphine. It's typically used as a continuous infusion, often in critical care settings. The crucial, immediate, life-threatening complication you have to know if that infusion is given too rapidly is chest wall rigidity. This isn't subtle. It's an acute, severe condition. The chest becomes rigid, leading to respiratory distress, potentially arrest. It requires immediate intervention, often mechanical ventilation, and sometimes even paralyzing agents to overcome it.
Wow, okay. And for morphine, the standard doses are pretty well known, but like you said, every professional absolutely has to have that antidote protocol memorized, ready to go.
The safety net is naloxone. That's the key. Dosed at 0.01 milligrams per kilogram the feet. That's the immediate reversal agent for opioid-induced respiratory depression. You need it on hand. Given morphine's inherent risks, respiratory depression, potential for increased intracranial pressure, even seizures at high doses, it's absolutely contraindicated in patients who are already in respiratory failure or have severe obstructive airway disease. You just wouldn't use it there. Okay, so we're shifting gears now. Moving from managing pain, both chronic and acute, to managing acute critical cardiovascular collapse. This whole section really requires mastering speed, precision, and those critical resuscitation protocols.
Right, and the administration technique for adenosine sounds almost surgical in its need for speed and location. Why is it so urgent? Why the rush?
Adenosine has an incredibly short half-life. We're talking mere seconds. So that initial dose, which is 0.1 millisecond, it has to be given as a lightning-fast IV push, like over just 1 to 3 seconds. And critically, it must be followed immediately by a rapid 5 to 10 milliliter saline flush. Typically, you'd use a 3-way stopcock for this, right into the largest possible vein closest to the heart. The speed is everything. It ensures the drug actually reaches the heart's conduction system before it gets chewed up and metabolized by enzymes in the blood cells. If that initial dose doesn't work within about 2 minutes, you double the dose and repeat the process. Side effects, thankfully, are often transient, but you might see things like chest pain, some shortness of breath, maybe even bronchospasm.
And we also need to flag the drug interactions here, don't we?
Yes, absolutely.
Yeah.
Using it at the same time as certain other drugs like carbamazepine, which is used for seizures, or dipyrimetal, significantly increases adenosine's toxicity and its effect. That demands extreme caution, maybe even a dose reduction if you have to use them together.
Okay. Atropine sulfate, another absolutely crucial emergency drug. We know its standard role for bradycardia, but its most critical, truly life-saving role seems to be in toxicology, right?
Exactly. Atropine is the absolute cornerstone for managing organophosphorus poisoning. Think pesticides. This poisoning causes a massive cholinergic overdrive. The body's rest and digest system goes into hyperdrive. And here, standard cardiac dosing is totally irrelevant. You forget those doses. You must dose high and repeatedly. We're talking 0.02 to 0.05 milligram kilogram IV every 10 to 20 minutes. And you keep going until you achieve what's called the atropine effect.
What exactly is that atropine effect? What is the prescriber looking for clinically?
It's the clinical sign that you're reversing the poisoning. You're looking for drying of secretions, the patient stops drooling, the lungs clear up, resolution of bronchuria, the pupils will dilate, and crucially, the heart rate starts to increase. You get tachycardia. Once you achieve that state, you're not done. Maintenance dosing has to continue, often for at least 24 hours, sometimes longer. That's because the organophosphorus compound can actually leach out of the body's fat stores over time, causing symptoms to return.
Right. Okay, procainamide and quinidine sulfate. Powerful antiarrhythmics, yes, but their chronic side effects seem to be among the most serious we've discussed so far.
They really do come with significant risks, especially with long-term use. Procainamide is strongly linked to severe hematological problems, like a granulocytosis, and maybe most notably, a serious autoimmune reaction, the lupus-like syndrome. Both drugs are strictly contraindicated if the patient already has conditions like heart block or myasthenia gravis, and quinidine is also generally avoided in congestive heart failure, CHF. The trade-off here is that these drugs are often reserved for serious arrhythmias that haven't responded to safer initial treatments. They're not first-line agents.
Phenytoin sodium is quite interesting because it pulls double duty, doesn't it? It functions as both an antiarrhythmic and a core tool for neurological stabilization, specifically seizures.
Yeah, its versatility means you need 2 distinct dosing strategies in your head. For arrhythmias, the loading dose is typically up to 15 milligrams per kilogram. But for the acute management of status epilepticus ongoing seizures, the loading dose is higher, 15 to 20 milligrams per kilogram IV. But here's the crucial rule, the administration rate. It must not exceed 1 to 3 milligrams per kilogram per minute. Push it too fast, and you risk causing acute hypotension, a sudden drop in blood pressure. And then with chronic use, you need long-term monitoring for things like gum hypertrophy, overgrowth of the gums, hirsutism, which is excess hair growth, and vestibulocerebellar syndrome, affecting balance and coordination.
Propranolol seems like the ultimate multitasker here. Arrhythmia control, hypertension management, and then these very specific pediatric applications like tetralogy spells and even infantile hemangioma.
It really covers a lot of ground. A tetralogy spell, that's an acute drop in oxygen saturation in babies with tetralogy of Fallot that requires an acute, slow IV push of propranolol. And for the treatment of infantile hemangioma, those common benign vascular tumors, which is becoming much more common now. You start low, typically 1 milligram per kilogram per day, and then carefully increase it to 2 milligrams per kilogram per day after about a week, assuming it's well tolerated. The key side effect to monitor, especially in cardiac kids, is a potential increase in pulmonary vascular resistance.
And what about verapamil? There's a very firm, specific contraindication there. Is the reason for avoiding it in young infants tied to the immaturity of their cardiac conduction system?
That is the essential reason, yes. Verapamil is a calcium channel blocker, and the immature cardiac conduction system in children under 2 years old is just exquisitely sensitive to its effects. This makes the risk of causing severe bradycardia, slowing the heart rate dangerously, or even complete AV block far too high. Therefore, it's strictly contraindicated below 2 years of age. Absolutely. As well as in cardiogenic shock or pre-existing AV block, of course.
Okay, shifting now to the inotropic agents. These are the drugs that give direct cardiac support, boosting contractility. Adrenaline or epinephrine seems to demonstrate the most extreme dosing difference based on its immediate purpose, right? Arrest versus support.
Exactly. The purpose dictates everything. The concentration you use, the dose, even the route sometimes. In full cardiac arrest, we use the highly dilute 1.10,000 solution, given IV or IO, intraosseous. Now, if you absolutely must use the endotracheal route, which we know is less reliable for absorption, you have to use the much stronger 1.100 solution, and you follow that with a saline flush and 5 quick ventilations to try and disperse it into the lungs. Now, contrast that emergency scenario with using it simply as a continuous infusion for inotropic support, just to help the heart squeeze better. The rate there is dramatically lower, only 0.1 to maybe 0.3 micrograms per kilogram per minute. Orders of magnitude different.
Dobutamine and dopamine are the workhorses for continuous infusion support. What's the key administration risk professionals really need to anticipate with these?
The main procedural warning, the one you really have to watch out for, concerns dopamine specifically. While both are often prepared similarly, using calculations based on body weight in the standard solution, dopamine carries a high risk of extravasation. That means it leaks out of the vein into the surrounding tissue. And dopamine is very caustic. It can cause severe localized tissue necrosis, actual tissue death. So you absolutely must ensure you have good central line access if possible, or if using a peripheral line, extremely vigilant, frequent monitoring of the IV site is critical.
Right. Now, the ultimate complexity in this cardiovascular section, I think, belongs to digoxin. The dose calculation sounds like a real tightrope walk, primarily because age dictates sensitivity so dramatically.
It is complex, and that complexity directly reflects the drug's very narrow therapeutic window. There's not much room between an effective dose and a toxic one. And the sensitivity variation with age is profound. Premature neonates, they are the most sensitive, requiring the lowest dose, maybe around 0.04 millimilli a day for maintenance, whereas infants, surprisingly, often require the highest dose per kilogram, maybe 0.06 to 0.08 milligauge a day. That's thought to be because of their larger volume of distribution relative to their weight. This extreme age sensitivity necessitates that careful, 3-stage loading sequence to gradually achieve the target therapeutic concentration without overshooting into toxicity.
Okay, let's detail that critical loading sequence. It sounds essential to get right.
It is. So you calculate the total digitalizing dose based on age and weight. Then you administer half of that total calculated dose stat immediately. Then you wait 8 hours and give a quarter of the total dose. You wait another 8 hours, so 16 hours from the start, and give the final quarter dose. Half, quarter. Once that loading is complete, the daily maintenance dose is usually just 1/4 of that total digitalizing dose, given once daily. And throughout this whole process, you have to be constantly monitoring for early signs of toxicity, things like nausea, vomiting, changes in heart rhythm like a Gemini pulse.
And the non-negotiable antidote, if toxicity does occur.
The antidote is the digoxin-specific Fab antibody, often called Digibind or Digifab. And you absolutely must know the calculation for reversal, or at least where to find it quickly. Roughly 60 milligrams of the antibody binds approximately 1 milligram of digoxin. You calculate the body load of digoxin to figure out the antibody dose.
Got it. And finally, we should just note norepinephrine and vasopressin primarily used for catecholamine refractory shock, noting the risks severe hypertension for norepinephrine and potential water intoxication for vasopressin.
Okay, moving into what feels like the strategic core of managing infectious disease, antimicrobials. Let's
Yeah.
start with the big guns, where hypersensitivity is always a major concern. Penicillins and cephalosporins.
Right. Every professional has to understand the full spectrum of penicillin hypersensitivity. It affects maybe 1% of patients overall, but the way it presents can vary wildly. You have the acute, immediate reactions, those are the life-threatening ones.
Yeah.
Anaphylactic shock, laryngeal edema causing airway closure, sudden hypotension. Very serious. Then you have the delayed reactions, which might appear days later, things like serum sickness with fever, rash, joint pain, or maybe a fixed drug eruption, a rash that appears in the same spot each time. I noticed the source specifically flagged piperacillin, often used with tazobactam, as impairing platelet aggregation. Is that a common enough risk that we should worry about it in routine use, or is it more concern for patients who are already compromised?
That's a really important clinical distinction. While piperacillin does impair platelet aggregation, it's generally only a major concern in patients who already have a bleeding tendency, maybe low platelets, or those receiving really large doses for prolonged periods. It's not usually an issue in short courses for otherwise healthy kids. However, another key technical detail, specifically for penicillin G, the intravenous form, is its high sodium and potassium content. It contains about 1.68 million Q of potassium per million units. So if you're giving very high doses, especially to a patient who's volume restricted or has renal impairment, you could actually induce seizures due to electrolyte overload, particularly hyperkalemia, something to keep in mind.
Right, and cephalosporins carry that added complication of potential cross-allergy with penicillin. What's the typical risk percentage usually cited for that?
It's generally estimated around a 10% cross-allergy rate. It's not 100%, but it's significant enough. This means you need to take a very careful allergy history. Fatal anaphylaxis, although rare, is still possible with a cephalosporin, even if the patient only reports a mild penicillin rash. Structurally, from a therapeutic standpoint, we really need to focus on the third-generation cephalosporins, drugs like cefotaxime, ceftriaxone, and septastone. These are the real workhorses for serious CNS infections. Why? Because they achieve high concentrations in the cerebrospinal fluid, the CSF. That's essential for effectively treating meningitis.
Okay, let's talk aminoglycosides. Drugs like gentamicin, tobramycin, amikacin, highly effective, especially against gram-negatives, but they have those two notorious organ toxicities. How do we strategically mitigate these risks in practice?
Yeah, the crucial side effects you absolutely must associate with aminoglycosides are 1, variable auditory and vestibular ototoxicity, potentially causing hearing loss or balance problems, and 2, reversible kidney dysfunction and nephrotoxicity. The strategic protocol to reduce this toxicity really centers on 2 things: adjusting the dosing interval and considering the mode of administration. If the patient's renal function is already impaired, you absolutely must reduce the dose and significantly increase the interval between doses. Give the kidneys more time to clear the drug.
And what about the strategy of once daily dosing? That seems counterintuitive, maybe, giving a bigger dose all at once.
It does seem counterintuitive, but it's a key pharmacokinetic insight. Administering the total daily dose as a single controlled infusion, rather than splitting it into multiple smaller doses throughout the day, actually exploits the drug's concentration-dependent killing mechanism. You get a high peak level, which kills bacteria effectively. Meanwhile, this allows the kidney tubule cells a longer period with very low drug levels, a drug-free interval, which lets them recover. Ultimately, this once-daily approach has been shown to reduce both renal and auditory toxicity risk, often without sacrificing efficacy. It's a smarter way to dose them.
Chloramphenicol. This drug has one of the most specific, infamous, and truly life-threatening side effects in the entirety of pediatric pharmacology. The gray baby syndrome. Why is this so incredibly specific to neonates?
This is a perfect, tragic example of developmental pharmacology in action. The gray baby syndrome occurs primarily because neonates, and especially premature infants, lack sufficient amounts of a crucial liver enzyme called glucuronidase. This enzyme is required to properly detoxify and metabolize chloramphenicol. Without it, the drug accumulates to toxic levels. This leads to a cascade of symptoms: abdominal distension, vomiting, profound difficulty breathing dyspnea, a characteristic ashen gray skin color, hence the name, cyanosis, peripheral circulatory collapse, shock, and potentially death. And this is distinct from the other risk of chloramphenicol, which is idiosyncratic, irreversible bone marrow depression or aplastic anemia, which can unfortunately occur at any age, though it's rare.
Okay, moving on from those. Macrolides, erythromycin, azithromycin, clarithromycin. They seem to carry a significant drug interaction risk that directly impacts the heart.
That's right. Besides the common side effects like GI upset, diarrhea, sometimes an abnormal taste, or cholestatic jaundice, the critical interaction risk with macrolides involves arrhythmias. Specifically, they can prolong the QT interval on an ECG, increasing the risk of potentially fatal arrhythmias like torsades de pointes. This risk is significantly higher when macrolides are used concurrently with other drugs that also prolong the QT interval, such as older antihistamines like terfenadine or estomazole, or the prokinetic agent cisapride, though these interacting drugs are mostly off the market now for this reason. It's worth noting that azithromycin generally carries a lower risk of QT prolongation compared to erythromycin or clarithromycin, which is one reason why it's often preferred.
Quinolones like ciprofloxacin, levofloxacin. Interesting here because the source notes a surprising lack of concern about an old toxicity fear, yet it highlights a different risk, this time to the neurological system.
Yes, historically there was profound concern about quinolones causing arthropathy damage to developing cartilage in children, based mainly on animal studies. However, the source material, reflecting current understanding, notes that accumulated clinical evidence suggests no concerns of arthropathy in humans at standard pediatric doses, so that fear has largely receded. The risks that do remain, however, are seizures. Quinolones can lower the seizure threshold, and significantly, they can inhibit certain liver enzymes, part of the cytochrome P450 system. This can dangerously elevate the levels of other drugs that are metabolized by the same enzymes, like theophylline used for asthma. That's a key interaction to remember.
Right. Among the miscellaneous agents listed, vancomycin really stands out, particularly regarding synergistic toxicity when combined with another class we just discussed.
Yes, vancomycin, a glycopeptide antibiotic crucial for MRSA infections, carries its own risks of ototoxicity and nephrotoxicity. But these risks are critically and significantly exacerbated when vancomycin is combined with aminoglycosides. That combination is highly nephrotoxic. For any professional prescribing both concurrently, which sometimes is necessary for severe infections, rigorous monitoring of renal function and drug levels with appropriate dose adjustments based on clearance is absolutely mandatory. You have to be extremely careful with that combo.
Anticycline, a newer agent, has a very specific age warning, likely related to effects on bone development similar to older tetracyclines.
Exactly. Ticycline, which is a glycylcycline antibiotic structurally related to tetracyclines, must be used with caution in patients below 8 years of age. This is due to the potential for effects on developing bone and teeth, causing staining and potentially affecting growth, similar to the well-known warnings for tetracyclines. So generally avoided under age 8 unless absolutely necessary.
Okay, let's pivot now from bacteria to the antifungal agents. We encounter amphotericin B first, a drug whose side effects are almost guaranteed, it seems. So much so that we have to plan the whole regimen around managing those known reactions.
Yeah, amphotericin B is notoriously toxic. It's incredibly effective against serious systemic fungal infections, but it comes at a cost. Some people jokingly call it amphoterrible. It requires meticulous preparation and very slow titration to try and mitigate the side effects. You always start with a tiny test dose, maybe 0.1 milligicilligen EV, to check for immediate severe reactions. Then you incrementally increase the dose daily, very gradually, working up to the target dose, which is usually a maximum of 1 milligram per kilogram per day. Slow and steady.
And beyond that slow titration, what are the critical administration protocols, things you absolutely have to do when giving it?
Two key things. First, it must be protected from light during infusion because it's photosensitive, it degrades in light, so cover the bag in tubing. Second, it must be diluted only in 5% dextrose solution. Saline will cause it to precipitate. D5W only. And yes, side effects are almost universal. Febrile reactions, fever, and chills during the infusion are very common, often requiring pre-medication. And the big ones are nephrotoxicity, kidney damage, and severe hypokalemia, low potassium levels, which needs aggressive monitoring and replacement.
There is liposomal amphotericin B, though, which offers an alternative with a potentially better safety profile, used particularly in systemic infections and, say, cryptococcal meningitis in HEV patients.
Correct. The liposomal formulation encapsulates the amphotericin B molecule within lipid spheres. This changes its distribution in the body, reducing direct exposure of the drug to the renal tubules. The result is generally less severe infusion-related reactions, fewer fevers, chills, flushing, and significantly less nephrotoxicity compared to the conventional deoxycholate preparation. It's much more expensive, but often worth it for high-risk patients.
Okay. Then we have the Isolate class, fluconazole, ketoconazole, itraconazole, voriconazole, they seem to share common risks of hepatic dysfunction and, again, multiple drug interactions.
That's the hallmark of the azole antifungals. They all require careful monitoring of liver function tests, liver enzymes, because of the risk of hepatic dysfunction, ranging from mild enzyme elevation to severe hepatitis. And they are notorious inhibitors and substrates of the cytochrome P450 enzyme system in the liver. This leads to extensive, often complex, and potentially dangerous drug interactions with many other medications. You always need to do an interaction check when starting an azole. There are also some specific risks to flag. Ketoconazole can cause endocrine side effects like gynecomastia. Uraconazole is known for causing unique visual disturbances, like blurred vision, changes in color perception, and photophobia. We should also quickly mention caspofungin and echinocandin. Its dosing is different. It's based on body surface area, many DM, not weight, and requires extra caution in patients with underlying liver disease. All right, let's pivot again. Now we're looking at agents used to clear out parasites, worms, and protozoa, and also viruses. Often, the treatment here can be curative, sometimes even with single doses, but it frequently relies on potentially quite toxic agents used for relatively short durations.
Albendazole, an amphimanthic for worm control, perfectly illustrates how the dosage and duration are entirely customized by the specific parasite you're targeting. It's definitely not a simple single-dose-fits-all situation.
Absolutely. The dosage regimen for albendazole is highly strategic and parasite-specific. For common roundworm or pinworm, yes, it might be a single dose. Simple. But for something like giardiasis, it requires 5 days of treatment. For high-dated disease caused by tapeworm cysts, it demands complex, prolonged 28-day cycles, often repeated multiple times, maybe even with breaks in between. And for neurocysticercosis, cysts in the brain, the typical 7 to 14-day course must be carefully administered alongside corticosteroids. Why? To manage the intense inflammation that occurs when the parasites start dying off in the brain tissue, the steroids prevent dangerous swelling.
Ivermectin, another antiparasitic, has a crucial contraindication based purely on age.
Yes, this is a hard stop. Ivermectin, while very effective for treating things like scabies and river blindness, onchocerciasis, is absolutely contraindicated in children below 5 years old. That's a non-negotiable safety rule due to potential CNS toxicity in very young children.
Praziquantel, used for tapeworms and also neurocysticercosis, carries specific neurological side effects we should be aware of.
Yeah, besides the usual GI upset, the notable neurological side effects with praziquantel are headache and vertigo or dizziness. These symptoms require careful clinical differentiation, as they could potentially be confused with symptoms of the underlying infection itself, especially in neurocysticercosis.
Okay, turning to antiprotozoals now. Chloroquine, used for extraintestinal amoebiasis and still sometimes for malaria, seems to have an immediate severe risk if it's administered intravenously.
That's a critical warning. While oral chloroquine is generally well tolerated, the IV administration bypasses the slower absorption from the gut. This can lead to very rapid high drug concentrations, with reports of sudden severe hypotension, dangerous cardiac arrhythmias, and profound cardiac depression, even cardiac arrest. It's a high-risk route that should really only be reserved for absolutely critical circumstances where oral therapy isn't possible, and even then, with extreme caution and slow infusion rates.
Metronidazole and tinidazole. They share uses for giardiasis and amoebiasis, and they also share one very distinctive side effect that patients frequently complain about, right?
They do. The common denominator for both metronidazole and tinidazole, besides being effective against these protozoa and anaerobic bacteria, is that very persistent, unpleasant metallic taste in the mouth.
Yeah.
Patients really notice that. They can also cause general GI effects like nausea, diarrhea, and sometimes leukopenia, a drop in white blood cell count.
And finally, for leishmaniasis, a parasitic disease spread by sandflies, the treatments pentamidine and sodium stibogluconate require specific monitoring, particularly cardiac monitoring.
Yes, both carry significant risks. Pentamidine, especially when given IV, can cause acute reactions like sudden breathlessness, fainting, hypotension, or even hypoglycemia right after administration. Needs careful infusion. Sodium stibogluconate, the mainstay treatment for many forms of leishmaniasis, is monitored meticulously for its cardiovascular risk, specifically the potential for prolonging the QT interval on the ECG. A prolonged QT interval increases the risk of serious ventricular arrhythmias, so ECG monitoring is crucial during therapy.
Okay, last group in this section, antivirals. Aciclovir dosing seems almost bespoke. It changes based not just on age, but on the specific viral target as well.
The dosing for aciclovir is indeed highly nuanced. It reflects both the severity of the specific viral infection and the patient's physiological maturity, especially in newborns. For instance, for neonatal herpes simplex virus, HSV infection, a very serious condition, the daily IV dose is calculated based on the baby's post-conceptional age. It's 40 mg for those under 35 weeks PMA, but a higher dose of 60 mg for those 35 weeks and older, reflecting differences in renal clearance. For varicella zoster virus, chickenpox, or shingles, the key point for oral therapy is the very narrow window of opportunity. It really only provides significant benefit if it's started within 24 hours of the rash first appearing. After that, its impact is minimal.
And the most serious shared side effect we need to flag for ganciclovir and its prodrug valganciclovir, which are crucial for treating cytomegalovirus, CMV.
The crucial note, the major toxicity for both ganciclovir and valganciclovir is the profound risk of bone marrow suppression. This can lead to significant cytopenias, specifically neutropenia, low neutrophils, anemia, low red cells, and thrombocytopenia, low platelets. This mandates rigorous and frequent hematological monitoring, checking blood counts regularly throughout the entire course of therapy. It's a major limiting factor for these drugs, #TAGVV, fluid, pressure, and hormonal regulation.
All right, now we move into the agents required for maintaining that delicate balance homeostasis, regulating blood pressure, fluid balance, and the endocrine system. Let's start with antihypertensives, often used in acute crisis situations.
Right. For a hypertensive crisis and emergency, labetalol is a common choice, often given as an IV push or continuous infusion. But it comes with two specific risks you need to anticipate. One, it can induce hypoglycemia, low blood sugar, especially in infants. And two, critically, because it has beta-blocking activity, it can worsen pre-existing asthma or bronchospasm. So caution is needed in kids with reactive airways.
Nitroprusside sodium, extremely effective for rapidly lowering blood pressure, but it seems to require a specific setup and has a strict dose ceiling.
It's a real powerhouse for rapid, titratable blood pressure control, yes, but it demands careful handling. First, it's extremely sensitive to light. It degrades quickly, so the solution and tubing must be protected from light, usually with an opaque covering. Second, because its effect is so potent and rapid, it demands continuous, ideally minute-by-minute invasive arterial blood pressure monitoring. You need real-time feedback. And crucially, there's the risk of cyanide toxicity with prolonged use or high doses, as cyanide is a byproduct of its metabolism. Because of this, the maximum infusion rate is strictly limited, typically to 8 to 10 micrograms per kilogram per minute. Exceeding that limit or using it for too long without monitoring thiocyanate levels is non-negotiable due to toxicity risk.
Okay. For the more chronic antihypertensive agents like captopril, an ACE inhibitor, and atenolol, a beta blocker, they have distinctive common side effects that are often the reason patients stop taking them, right?
Exactly. Compliance can be an issue. Captopril and other ACE inhibitors are notorious for causing a persistent, bothersome, dry cough. This is due to their mechanism of action involving peranakin. Atenolol and other beta blockers often cause general tiredness, fatigue, or exercise intolerance, which patients may find limiting. We should also note for amlodipine, a common calcium channel blocker, that dose reduction is typically needed in patients with significant hepatic insufficiency, as is metabolized by the liver.
Okay, moving to diuretics now controlling volume. Acetazolamide seems to have quite versatile uses, far beyond just simple edema control.
It does. Acetazolamide is a carbonic anhydrase inhibitor, which gives it unique properties. Yes, it can be used for edema, but it's also used sometimes for certain types of epilepsy, for glaucoma, to reduce intraocular pressure, sometimes adjunctively for hydrocephalus. And notably, it's used for pseudotumor cerebri, or idiopathic intracranial hypertension, where the dose might be titrated incrementally way up, potentially to a massive 100 milligrams per kilogram per day. However, because it works by inhibiting bicarbonate reabsorption, it can cause metabolic acidosis. Therefore, it's strictly contraindicated in patients with marked hepatic or renal dysfunction, as they can't compensate for the acidosis.
Furosemide, or furosemide, the loop diuretic, has well-known electrolyte risks like low potassium, but also a specific, potentially permanent long-term toxicity related to hearing.
That's correct. Besides the common risks of metabolic alkalosis, hypokalemia, low potassium, and hyperuricemia, high uric acid, prolonged use of furosemide, especially at high doses or via rapid IV injection, carries a significant risk of ototoxicity. This can manifest initially as tinnitus, ringing in the ears, but can progress to temporary or even permanent hearing loss. This necessitates careful monitoring, particularly when it's used concurrently with other potentially ototoxic drugs like aminoglycosides.
Spironolactone is unique among the diuretics because of its side effects profile, which is distinctly hormonal.
Yes, spironolactone is a potassium-sparing diuretic, but its mechanism involves antagonizing aldosterone, which is structurally similar to sex hormones. As a result, its side effects are directly related to this hormonal activity. In males, it can cause gynecomastia, breast enlargement. In females, hirsutism, excess hair growth, or irregular periods. And of course, because it spares potassium, the primary risk you always monitor for is hyperkalemia, high potassium levels, especially if used with ACE inhibitors or in renal impairment.
Mannitol, another type of diuretic, an osmotic one used for acute needs like cerebral edema. Its main danger seems to be causing instability due to rapid fluid shifts.
Precisely. Mannitol is a potent osmotic diuretic. It draws fluid out of tissues, like the brain, and into the bloodstream to be excreted by the kidneys. Its primary danger lies in these rapid, massive fluid shifts. This can cause acute hypotension if the intravascular volume drops too quickly, or conversely, fluid overload if renal output can't keep up. It can also cause severe fluid and electrolyte imbalances, hyponatremia, etc. Requires constant hemodynamic monitoring and careful fluid balance assessment during use.
All right, now the hormones, specifically corticosteroids. We absolutely must start by understanding that foundational glucocorticoid hierarchy, the equivalence chart for dose substitution.
Yes, this hierarchy is absolutely essential for safe practice, especially when switching between different steroid preparations or routes. The source provides the key equivalence ratios you need to know, roughly. Prednisolone 5 milligrams is equivalent in anti-inflammatory effect to 0.75 milligrams of dexamethasone, 4 milligrams of methylprednisolone, and 20 milligrams of hydrocortisone. This conversion chart must be your guiding principle when, say, switching a patient from IV hydrocortisone to oral prednisolone or when calculating stress doses. You have to get the equivalence right.
Dexamethasone, being potent and long-acting, has some highly specific emergency uses mentioned, like cerebral edema and croup.
Exactly. For acute cerebral edema, often related to tumors or trauma, the typical dose is around 0.5 mg/kg IV or IM, usually given every 6 hours initially. For croup, that viral inflammation of the upper airway causing a barking cough, a single dose of dexamethasone, often 0.3 to 0.6 mg/kg given orally or IM, can be remarkably effective in reducing airway swelling quickly. It's also used in very high doses, sometimes called pulse dexamethasone therapy, for certain severe autoimmune or inflammatory conditions.
Here's a really key strategic discussion point. The stark, dramatic difference between the side effects seen with short-term versus long-term corticosteroid use. What's the fundamental mechanism behind those dangerous long-term effects?
This is critical for any professional prescribing steroids. You always have to weigh the urgency and benefit against the duration and risk. The fundamental long-term danger relates to the suppression of the body's own natural stress response system, the HPA axis, the hypothalamic pituitary adrenal axis. Short-term risks, we're talking days, maybe a couple weeks, they're generally manageable. Things like transient glucose intolerance, high blood sugar, maybe some mood changes, increased appetite, potential for hypokalemia, and some reversible HPA axis suppression.
But the long-term risks, those associated with weeks or months of use, they sound potentially life-altering.
They absolutely can be. Prolonged steroid use, typically more than 2-3 weeks, leads to significant and potentially prolonged HPA axis suppression. The body essentially stops producing its own natural cortisol. This leads to a host of serious, potentially chronic issues. The characteristic Cushingoid appearance, moon face, central obesity, thin skin, osteoporosis leading to fractures, cataracts, increased susceptibility to infections, hypertension, and crucially, in a developing child, growth retardation or stunting. This requires extremely careful risk mitigation, using the lowest effective dose for the shortest possible time, and planning for careful tapering when stopping.
ACTH, adrenocorticotropic hormone, sometimes used for infantile spasms, has quite an extensive list of absolute contraindications listed.
Yes, ACTH is a potent therapy, stimulating the adrenal glands directly. But because of its profound systemic impact, it's contraindicated in a number of situations. Patients with acute psychosis, active congestive heart failure, significant pre-existing hepatic damage, active systemic fungal infections, active peptic ulcers, and those who've had recent surgery. It reflects the widespread effects of intense steroid stimulation.
Lastly, in this section, thyroxine, thyroid hormone replacement. The dosing shows a massive difference between newborns and older children, right?
A huge difference, yes. Newborns diagnosed with congenital hypothyroidism require the highest dose on a per kilogram basis, typically starting around 10 to 15 micrograms per kilogram per day. This reflects the absolutely critical need for adequate thyroid hormone levels for normal neurological development in the first few months and years of life. This dose then drops significantly, maybe down to around 5 micrograms per kilogram per day in older children as their metabolism changes. And it must always be taken orally, ideally on an empty stomach, usually 30–60 minutes before breakfast, for maximum and consistent absorption. We should also briefly note the thyroid suppressants mentioned: potassium iodide, SSKI, and Lugol's iodine. The key difference is concentration. SSKI is vastly more potent, containing much more iodide per drop than Lugol's. Hashtag tag check speech, emergency support, and neurological agents.
Okay, let's wrap up this deep dive by looking at the critical support mechanisms, things like antidotes, gastric meds, and agents for neurological stabilization. These often demand the highest level of vigilance and quick action.
Absolutely. Starting with antidotes, often found in Table 30.N0 in resources. Ipecac syrup, historically used to induce vomiting after ingestions. There are two absolute procedural contraindications regarding its use. We need to know these calls.
Right. The source says, do not use Ipecac syrup in a semi-comatose child or after charcoal administration. Can you explain the rationale for both of those? Why are they absolute no-goes?
Okay, first, in a semi-comatose child, someone with a decreased level of consciousness, the risk of aspiration is massive and potentially fatal. If you induce vomiting, they can't protect their airway effectively and could inhale the vomit into their lungs, so absolutely not. Second, if activated charcoal has already been given to absorb the poison in the gut, giving Ipecac syrup afterward would simply cause the child to vomit up the activated charcoal, completely defeating the purpose of the charcoal administration. It makes no sense. So never after charcoal, though Ipecac is rarely used at all now.
Makes sense. Deferoxamine, the chelating agent for iron poisoning, requires not only an absolute maximum dose limit, but also a key contraindication.
Yes. For treating both acute and chronic iron overload, the maximum dose for deferoxamine via continuous IV infusion is strictly limited to 6 grams per 24 hours. That's the ceiling. And it's contraindicated in patients with severe renal failure or anuria, no urine output. Why? Because the iron deferoxamine complex, once formed, must be cleared from the body by the kidneys. If the kidneys aren't working, the toxic complex can accumulate.
Dimercaprol, or BAL, used for heavy metal poisoning like lead or arsenic, carries a crucial genetic risk. We need to define that term mentioned.
Right. Dimercaprol carries the risk of causing hemolysis, the breakdown of red blood cells, specifically in patients with G6PD deficiency. That stands for glucose 6-phosphate dehydrogenase deficiency. It's a fairly common inherited enzyme deficiency. It makes red blood cells extremely vulnerable to oxidative stress. When these individuals are exposed to certain triggers like fava beans infections or specific drugs including dimercaprol, their red blood cells can break down rapidly, causing hemolytic anemia. So you need to know G6PD status if possible before using it.
Got it. And for organophosphate poisoning, we already talked about atropine being the cornerstone. It's used alongside pralidoxim, right? What does pralidoxim add?
Pralidoxim, often abbreviated as 2-PM, typically dosed at 25 to 50 milligrams per kilogram, works differently from atropine. Atropine manages the symptoms of cholinergic excess. Pralidoxim, ideally given early, works to reactivate the enzyme, acetylcholinesterase, that the organophosphate has inhibited. This reactivation is particularly crucial for reversing the muscle paralysis, including respiratory muscle weakness caused by the poisoning, so they work synergistically. Atropine for secretions and heart rate, pralidoxim for muscle strength.
Okay, moving to gastrointestinal agents. Domperidone and metoclopramide, common antiemetics used for nausea and vomiting. They share a very serious, often dramatic neurological side effect profile.
Yes, this is a really important one to recognize quickly. The most common and potentially severe side effect for both domperidone and metoclopramide is extrapyramidal disorders, or EPDs. These are drug-induced movement disorders. They can manifest acutely as dystonia, sudden involuntary muscle contractions, maybe of the neck, torticollis, or face, or, frighteningly, as an oculogeric crisis where the eyes involuntarily deviate upwards. Less commonly with short use, but possible, are akathisia, restlessness, or Parkinsonism-like symptoms. Tardive dyskinesia is more with long-term use. Professionals absolutely must recognize these immediately, stop the drug, and sometimes treat with anticholinergics like diphenhydramine. Domperidone also carries a rare risk of cardiac arrhythmias.
Right. The acid control agents, the proton pump inhibitors, PPIs like omeprazole, lansoprazole, and the H2 blockers like ranitidine and famotidine, they seem generally safer, but lansoprazole is specifically noted as being well tolerated.
Generally, yes, the acid suppressants are well tolerated for their common uses like GERD or peptic ulcers. Ranitidine, famotidine, H2 blockers, omeprazole, lansoprazole, PPIs, are used routinely. Lansoprazole is often highlighted as being particularly well tolerated, with side effects typically being mild and similar to omeprazole, things like headache, diarrhea, or abdominal pain being the most common.
though long-term PPI use has other potential concerns like nutrient absorption.
Okay, shifting to neurological stabilization. Diazepam, Valium, a benzodiazepine, is a standard anticonvulsant and sedative, but it's contraindicated in a couple of specific conditions.
Yes, diazepam, while widely used, is contraindicated in patients with myasthenia gravis. This is because its muscle relaxant properties can significantly exacerbate the muscle weakness characteristic of that disease. It's also generally contraindicated in acute narrow-angle glaucoma, as benzodiazepines can potentially increase intraocular pressure in that specific type of glaucoma.
Flumazenil is the specific antidote for benzodiazepine overdose or sedation reversal. What's the critical strategic reason for that careful, slow titration regimen described for its use? Why not just give the full dose?
Flumazenil acts very rapidly to reverse the effects of benzodiazepines at the receptor level. The critical risk of immediate rapid reversal, especially in a patient who might be physically dependent on benzodiazepines, even therapeutic use, is that it can precipitate acute withdrawal symptoms, including potentially severe seizures. Therefore, the dose is always titrated very carefully and slowly. You give an initial small dose, maybe 0.01 milligram per kilogram over 15 seconds. You wait, observe the response, and repeat the dose every minute if needed, up to a maximum cumulative dose, typically around 0.05 milligram per kilogram, or an absolute max of 1 milligram total. Slow and steady avoids precipitating seizures.
Right. Midazolam, Versed, another benzodiazepine used very frequently for procedural sedation or continuous sedation in ICU. The critical side effect to constantly monitor for is profound respiratory risk.
Absolutely. Midazolam, especially when used in continuous infusions for prolonged sedation or even with bolus doses, carries the critical risk of causing severe respiratory depression and potentially shock. This requires vigilant, continuous monitoring of respiratory rate, oxygen saturation, and blood pressure, and immediate availability of airway management equipment and reversal agents like flumazenil. You cannot be complacent with Midazolam sedation.
Okay, looking at the other heavy-hitting anticonvulsants often used for refractory status, epilepticus, phenobarbital, pentobarbital, pentothal, thiopental, they all seem to share acute hemodynamic risks during the loading phase.
They do. These barbiturates are very effective at stopping seizures, but they all share the significant risk of causing acute dose-dependent hypotension, low blood pressure, and respiratory depression during rapid 5V loading. This means that whenever you're loading these drugs for status epilepticus, you must anticipate the need for and have immediately available ventilatory support, like intubation equipment, and circulatory support, like IV fluids and vasopressors. Pentothal, or thiopental, carries an additional specific risk of causing laryngospasm or bronchospasm.
Valproic acid, Dipicote, a cornerstone agent for many seizure types, requires quite high doses sometimes, achieved through careful titration.
Yes, valproic acid is used broadly for both generalized and partial seizures. Therapy often starts low, but the dose is typically increased incrementally, often on a weekly basis, potentially up to a very high maximum dose, sometimes cited as 60 milligrams per kilogram per day, to achieve seizure control. This gradual titration helps manage side effects but requires ongoing monitoring, particularly for liver function, hepatotoxicity risk, and platelet count, thrombocytopenia risk.
Finally, let's wrap up with these critical micronutrients and parenteral support agents. Many of these demand specific calculations before you can even think about administration. Let's start with parenteral iron therapy. That calculation looks complex.
It is detailed, but it's essential for calculating the correct amount of iron needed. Parenteral iron therapy requires using the total iron deficit calculation formula. You can't just guess the dose. The formula is essential because it accounts for 3 key variables: the patient's body weight, the magnitude of the iron deficiency, the difference between their target hemoglobin and their actual hemoglobin, and crucially, the amount needed to replenish the body's iron stores, depot iron.
Okay, can you break down those calculation elements for us?
Sure, the formula typically looks like this. Total iron deficit in milligray equals weight in kilogram multiplied by target hemoglobin, actual hemoglobin, both in GDL, multiplied by a constant factor, usually 2.4, US, the estimated depot iron needed in milligram. And that depot iron value itself changes based on the child's weight. The source mentions typical values like 15 milligrams for children weighing less than 35 kilograms and a flat 500 milligram for children weighing over 35 kilograms. It's also really important to note clinically that the newer intravenous iron preparation, iron sucrose, generally has significantly fewer acute infusion reactions compared to the older iron dextrin formulations, which often required a test dose.
Right. Calcium gluconate. used for hypocalcemia, must be given as a slow IV infusion under cardiac monitoring. Why the absolute urgency for cardiac surveillance during infusion?
Calcium is critical for cardiac muscle function, but rapid infusion of intravenous calcium can be dangerous. It can cause life-threatening bradycardia, slow heart rate, other arrhythmias, and hypotension. So continuous ECG monitoring and slow, controlled infusion rates are mandatory. Furthermore, calcium gluconate solution is extremely irritating to tissues. If the IV line infiltrates and the solution extravasates leaks out of the vein, it can cause severe localized tissue necrosis and skin sloughing. So ensuring line patency before and during infusion is absolutely critical. Check it frequently.
And sodium bicarbonate, used to correct severe metabolic acidosis, requires a calculation based on the base deficit before administration.
Yes, you don't just give arbitrary amounts of bicarbonate. The precise dose needed in MEQ is calculated using the patient's base deficit, which is derived from blood gas analysis. The common formula is dose, MEQ, base deficit multiplied by weight in kilogram multiplied by a factor representing the bicarbonate base, often estimated as 0.6, though sometimes 0.3 or 0.5 is used. This precision is necessary because administering sodium bicarbonate carries significant risks itself. It can cause hypernatremia, high sodium, metabolic alkalosis if you overshoot, fluid overload, and critically, especially in fragile neonates, rapid shifts in osmolarity from bicarbonate administration have been linked to an increased risk of intracranial hemorrhage. So calculate carefully, give slowly.
Lastly, vitamin A. There's a routine prophylaxis schedule, but also a specific high-dose treatment schedule for measles.
That's right. The routine prophylaxis schedule recommended in many parts of the world involves giving vitamin A alongside routine immunizations, typically 100,000 international units orally around 9 months of age, often repeated later. But for children diagnosed with measles, vitamin A supplementation is crucial because measles depletes vitamin A stores and deficiency worsens outcomes. In this case, a specific high-dose administration schedule is required. Give a dose immediately on diagnosis, day 0, repeat it the next day, day 1, and sometimes a third dose is given later, maybe at day 14 or day 28, especially if malnutrition is present. The exact dose depends on the child's age category, under 6 months, 6, 11 months, 12 months, and older. So we have, I think, thoroughly navigated the foundational principles, those specific, sometimes life-saving dosing regimens, and the absolutely critical adverse effects across pretty much every major drug class covered in this foundational material. The absolute necessity of adjusting therapy based on those developmental factors, the specific disease state requirements for penetration, and just meticulous, informed monitoring that really is the professional standard we're aiming for.
Yeah, we've definitely wrestled with some core strategic challenges today. Thinking back, the things that really stand out are that absolute non-negotiable RAE warning for aspirin in kids. Can't forget that. The stark, almost frightening contrast between the short-term side effects and the long-term consequences of HPA axis suppression from corticosteroids. That almost surgical technique required for rapid adenosine administration speed is everything there. The essential complexity but necessity of getting that parenteral iron deficit calculation right. And, of course, the immediate recognition required for chloramphenical's devastating age-specific toxicity in neonates.
Absolutely. And this deep dive really shows that even with decades of standardized medical data, rationality in drug therapy requires constant vigilance, critical thinking, and that strategic foresight we talked about. Knowing the drug, its mechanism, its dose, that's really only half the battle, isn't it? The true mastery, I think, lies in anticipating that complex interaction between the dose, the known toxicity profile, and the unique, ever-developing physiology of the individual pediatric patient in front of you.
So we'll leave you, our listeners, with this final provocative thought to mull over. Given this high-stakes environment of pediatric pharmacology we've explored, what specific monitoring parameter, maybe it's renal function when using an aminoglycoside, or perhaps it's the cardiac rhythm during digoxin loading, maybe HPA axis function surveillance after stopping steroids, or even just the platelet count during that tricky biphasic aspirin dosing for Kawasaki, what single parameter stands out to you as the most critical factor, the one sentinel marker for achieving true therapeutic mastery, and maybe offering the earliest possible warning sign of imminent disaster? Something to think about.